This material is made available to you by or on behalf of the University of Melbourne under Section 113P of the Copyright Act 1968. It may be subject to copyright. For more information, visit the University Copyright website.
Good afternoon, everybody. Firstly, I want to just say how happy I am to be among such esteemed people who are very human-centred, human-focused. It's also quite testament to Professor Chong and Michelle Dowsey to come and discover us in their sort of seeking out and trying to find other models and other methods for them in their pursuit of disrupting and possibly looking at other alternative pathways, other models. And this partnership really through Design Factory and the Everson Institute located at Swinburne Uni and these two sort of detective sleuths has been a fantastic journey for us so far. Design Factory Melbourne is where I am the director of, is one of, as Peter mentioned before, one of many you'll see in a minute now, 24, 25. We are dedicated really to creating the conditions for innovation. Now that sounds like a nice spiel, but the heavy lifting in that is that it is a group that constantly wants to work across silos, working in interdisciplinary teams, and using methods appropriate to the problem context. We are this many and growing, and the reason why this is so popular is because we're able to act local but go global, and that there is a shared series of methods and a shared passion to have a crack at the wicked, gnarly problems that we really know nothing about. You're the experts in the room, but we have ways in which we can get disciplines from different domains to work together and potentially see each other's perspectives and models through design research to imagine something at sometimes that's unimaginable. So the key aspects to that, of course, are the space and the environment and the mindset in the community and the culture. That seems, again, quite simple, but it is a tricky task to keep people from professors, industry partners, CEOs, students, researchers, people from all walks of life to work towards shared meaning. And this is a critical element in the building and the collection of data and the gathering of information and visualising it in new ways. So I just wanted to quickly be less clear on what design for us means. Is essentially it's an approach to problem solving, and innovation is that it has to solve a user need, it has to be novel and has to have impact. We have a swear jar for the word innovation. You put $50 in if you can't substantiate it in our space because it is a real catch cry. And it's a funky word at the moment, but without it actually having real demonstration, it's just another one of those fads. And we really work across the boundaries. That is our comfortable space. And more recently, we have employed and included people from occupational therapy, across medicine, across science, across even astrophysics, to come and work in our teams to try and look at the wicked problems that are brought to us and look at other perspectives. This little graphic is quite a common one that we use. Particularly recently, I've been talking to the people in the automotive industry, where the rush and the pressure to sort of get to the answer versus, you know, spending that early ideation time, and it seems like it's not worthwhile in this early prototyping, fail fast, fail forward stage. But we keep seeing that the cost of error, if you don't spend that early ideation time and make those mistakes and trial and look at other opportunities and perspectives, is really something that we see with other organisations and other sectors. And the beauty is that Michelle and Peter have seen that there could be something in that. So, of course, very much everything is human first, user first, patient first. It's got to be, because without that, we really don't get to understand experience. Just one quick example, when we work with Philips and the process of that early ideation phase is that if we couldn't crawl into the machine and we couldn't trial it and we couldn't lie in there and we couldn't mess around with different prototyping elements, we wouldn't have been able to work on these kind of aspects. Here, you know, we want to, with high-intensity focused ultrasound, lower the time spent in there because it gets hot and skin hurts, and we wanted to figure out how is that possible to reduce that. None of us are experts in that field, but without that diverse team having a crack at it, we wouldn't have come up with what we have today. So we know, though, there are perils with the giant vision, the grand author, the super expert. We know that reliant on a single vision can be risky, and that's why collaboration is key, and diversity of knowledge sets. We also know that the hardline theory or intention, you know, the difference between what is said to be done and the reality, and we see this all the time, and we see this across many disciplines. The user and the experience in their world is paramount, and I've heard that all morning, all day. But we also know that if we're not able to mess about with our partners and get them out of their comfort zone and get them to trial things themselves or get them to experiment with something that's not yet imagined or visualised, and that's why the culture and that's why the mindset space in the design factories where you can, you know, put on a funny skirt with cushions and pillows and walk around. Well, today this skirt with its fantastic little pads can be worn by people who have, especially in Northern Europe when it's icy and slushy, you can wear a nice skirt with a bit of padding, and if you fall, it's not so bad. We can also look at different models in which we can experience, through prototyping, different elements in which people can speak to each other and communicate. Point being is that we have to make the tacit explicit. The point of prototyping and the point of testing and looking at new models of visualization is that it has to be ubiquitously understood. It's got to be communicated to anyone. And in your line of work, the data sets, I believe, have to be understood by the patient and the doctor and the politician all at the same time. If we can't do that kind of high-level, high-risk experimentation, as we have done with our partner in the design factory in CERN in Geneva, you know, it was actually not a designer. This person was an astrophysicist who was suggesting, you know, why can't we get our food fridge to send, you know, messages? And at the moment, what's happening with all that waste in hospitals and in our kind of answering the UN Sustainable Goals process, we're looking at, you know, how could this look like in 2030? What is possible? Again, maybe out of 200-300 of these kind of high-risk, early-stage, minimal viable product projects, maybe one will stick, but it's worth that level of expense, time, team management, ego management, interaction, support of different disciplines speaking to each other, and ways of communication. We highly think it's worth it. So for us, and this is mainly Nicole's work, is that, you know, I didn't know. There's a lot of things I learned in this process. For innovation, healthcare in Australia, in terms of affect and policy, is still burgeoning. But design for health is not new. If, again, thanks to Nicole, that since the 60s, this is a fantastic model, and it's a really good argument if ever you need to think about integrating design for health in your own organisation. Bruce Archer, he's recognised as one of the founders of design research, and he really established the sort of principles of evidence-based research. And it was really due to at that time, I think 300 different types of beds, all made by different providers with various levels of efficacy. Meanwhile, nurses' backs were getting sore, patients were falling out, walls were getting dinted, the whole palaver. And he basically came with his team through a process of developing a systemised, standardised bed, which I think is still on today, give or take. But the point is that design for health is able to broker across different communities of practice, get people to work together in a way and use design tools to trial and test. So what was amazing for me is the level of that, if you go back to that early graph, the amount of time spent in that early identification prototyping phase. It took 1,000 beds, 1,000 hospitals, many prototyping beds for that to be whittled down, tested over quite a significant period of time. But it was worth it. So really, today, we know design for health is really about tackling, complexity in the healthcare system. That's it. But the way I like to think about it is you have this data, and it has to be built into some sort of cohesive information. And it's really important that that information is presented so it's embodied. It can be embodied, it can be read, it can be heard, it can be understood in ways that you're not typically seeing, and sometimes that can shift your way of thinking and give you opportunity to pull on other elements of research that are unexpected that could hopefully enrich your mission. Because finally it's in the eating, it's in that translation or consumption, that's when action happens. So, for the medical field, what does design mean really is that it's about changing experiences, creating new products, and ideally affecting policy, and all those other things we've heard this morning. I'm just thinking of a quick one or two cases here. Is Colin, who worked on the Empowered Patient Project, one of our PhDs. He was looking at different ways that technology can better enhance the patient external experience. But out of that, one of the most interesting things was that the medical profession always thinks about the individual and the individual's need. But here we are finding that actually the social experience and the data experience and the tech experience of the experience of the group actually had effect on the individual. And that in itself was quite powerful. If I think about what Nicole is doing with Michelle and the team, really here, in order to redesign a pathway, she's looking at different models of storytelling and narrative, and to convert that into design language, to be able to form maps or blueprints or models or storyboards or sculptures, or we don't know what that necessarily will look like at the end. We have some ideas, but to do that, we of course rely on a whole smattering of different design recipes, if you like. And the common one that you guys might already know is the double diamond by the UK Design Council, where you're converging and diverging. The other one that in Design Factory we typically use is, is it desirable, is it viable, is it feasible? And if I think about some of the early stage feedback we're getting with Nicole's and Michelle's and the team's work is here. You see this comment and you think, is it desirable? Is this really a desirable state? And then we look at this, the other one about the coordinator calling the person up. Is that feasible? Does that mean it's better quality? How do you know that the patient shouldn't call the person up twice a week? Is this something that's sustainable, feasible at all? And then, this one, is it viable? great, it's a dream come true, it's a wonderful clinic, it's a wonderful opportunity. But, you know, how can we keep quality and scale? And does quality typically mean at the cost of scale? We don't think so, and we hope that we find different types of understanding and visualization for us to look for other opportunities that maybe isn't obvious or necessarily clear within your own data sets. So for us, what we are thinking of more and more is really about how we're able to uncover complexity and look at those levels of macro to micro and the sandwiches in between of layers. And one of the things I'm thinking of with Nicole is that how we can get multiple perspectives again, from the tacit to the overt, from the knowledge around how many surgeries were cancelled in one morning, which Bruce was telling me about before, versus large impact scale data around insurance. And I think for us, one of them is around live, ongoing gigamap aspects, which I think could be utilised for some aspects around the smart registry. And of course, the ability, if you think about the stock market and the interfaces there, the ability to be able to drill down quickly and then pull back, but also have some real, when we go back to the cake and data metaphor, have some real understanding of that. So our patients, as well as our experts, have that same amount of knowledge, and that is easier to access. So a couple of other quick case studies where the intervention, early intervention of design for health research has made some of your language the norm. So if you think about, visual care journeys and patient care and patient plans, and this kind of language that we're seeing today, co-design, patient-centred, patient-led, these terms have come from that, 10, 15 years of design for health intervention. And similarly, with, if I had $1 for every time someone said to me, can you help us develop an app? Well, we can, but we won't until we understand what really is the need. Because if it's about knitting something or throwing paper planes or building an ark, that may be the answer rather than the app. But again, design research is able to bring about new possibility and then make the user's need the norm. Just finally, I always love showing this. Again, I was showing this to the car geeks who if I think about the way in which in autonomous vehicle research, the amount of service touch points and the amount of design integration along the journey, if I think about the way in which those researchers look after cars and car technology, if we could apply almost that similar process to the way in which we look after humans, the investment would, and if there could be almost similar investment, I wonder what those results would be. But the design integration as an investment and an increasing influence in the improvement of an organisation's value proposition is something that I think that is always a good reminder. Okay, unfortunately they're like the alpha products in the room, but this also can happen in terms of social intervention and good social design as well, for not only for profits, but for non-profits. So pretty much I just really wanted to thank you to listening to me, to understand that for us, design intervention with health is about, tackling these complex, gnarly, human problems that can't be solved by any one discipline. And I'm very glad that I have the opportunity to thrash about in our process of looking for new pathways and new models of research in the osteoarthritis sector with Michelle and Peter to see what we will uncover and hopefully also share this knowledge and also get back from our other partners in the network. So thanks.
We've got time for questions.
That's good.
Oh, Peter. Sorry, you can't get away now. Stay here.
Sorry, Anita, not that fast. Look, it's just wonderful, and I'm just about to tweet your last slide here, because it
Cool, I'll
raises
send it.
it raises a fascinating question. Well, a fascinating state that I've come to appreciate more, and that is when you design something such as a car or an apple or anything that has become successful in society, it's really a combination of all the good things we want out of a product, but being able to connect,
Yeah,
because someone has to buy the product.
yeah,
So in health, if we were to design the best, most efficient, the most cost-saving, safe product that
Yeah.
produces the best outcomes,
yeah.
how should we and who should we target the connection with?
Yeah, good question. Very good question, and that's why I'm here. No, you think about it, you know. You and Michelle are bringing other alternate perspectives and other models of doing, because honestly, when I go back to what's going on in Stuttgart, to the way in which they're treating the whole, if I use that analogy, the whole city to be ready for self-autonomous vehicles, which does mean everything from the sign on the wall through to the school, you know, to the lights on the road, but not only that, but the school operating systems, the workflow, like, so it's a whole innovation ecosystem concept. And if we could, if we could do a trial, maybe with 100,000 people or something, where we could treat this health problem, this system that you have exposed me to, in the same way that we would treat the planning as a service design problem for self-autonomous vehicles, I wonder what we would come up with. I don't know, but you guys are figuring it out, and I'm glad to be part of it.
Any other questions? We've got one up here. None of there is industry driven. How often is it approached directly by the health department or ministry? So I guess it's a question about when do governments drive this kind of stuff, or the hindrance?
Governments don't like, well, they're getting there. I mean, you know, you think about we now have, you know, we now have innovation written into some government sectors. And of course, we work with different non-for-profits as well. But remember that graph early on, it's expensive to outlay for risk. It's expensive to work with us because you're not necessarily sure about the outcome. Having prototypes, whether it's a product, service or system, okay, it's easier just to say product, but it can be service or system. To do that early ideation, unpacking and failure and redesigning and retrialing and getting people to work through those processes doesn't make nice for ministry or government headlines. You know, we tried, we spent 200,000 on it, didn't work. Oh well, we learned a few things, maybe next time. You know, that's not going to happen. That's not in our mindset in this culture. But hopefully we're changing that. What's RCTs?
Randomised controlled trials.
Right.
So I guess it's probably about the nature of the development of what the intervention might be. RCTs, I guess the interventions are often very, very narrow and experimental, and you're looking at the social system.
Yeah. So the randomised controlled trial is what we would like to get, and then we would like to then typically what we would do is put it through other avenues or other filters or other modalities. Because we're not as because we are not the knowledge holders, you are. We are interested in pushing the boundaries of what you're doing and trying to, well, here particularly, I'm particularly passionate about this space, but for us, if we can put it through other filters or trial with other disciplines. One of our areas, one of our design factories in CERN in Geneva is really, you know, we're sitting there with a bunch of physicists who are running the largest atom smasher in the world, the Hadron Collider, and those physicists are working with the designers to answer UN sustainability goals. If we could not have that diversity, you know, I think that's that place at the boundaries, I think that's very important to be able to come across and at least challenge or put a scratch in the iceberg of such wicked problems that you're proposing today.
Okay, thank you very much. Anita,